Are people able to see my screen okay? Awesome. All right, so go ahead and share your name, pronouns, agency, and role in the chat. And we will get going with our agenda for this morning. So we're going to start with some announcements and updates from across the East Bay. Then we're going to have a presentation from Finn Black on caring for people who use methamphetamines. We're actually going to switch the order a little bit and then get some updates from the Bliss study that's being carried out of SFDPH, but looking at some patterns of use of people who inject drugs across the East Bay as well. And then we're going to hear from Caitlin Wallace from La Familia. And she's going to tell us a little bit about the East Bay Recovery Incentives Program for people who are using stimulants that's available and enrolling folks right now. Right. So first we'll start with some updates and announcements. Do we have folks from Alameda County Health Department here yet?
Hey, Sammy, I'm here. I'm not sure if Dot's
Perfect.
in yet it or not, but I'm here.
Perfect. Steve, you want to jump in?
Sure. Hi, I'm Steve Gibson. I'm the HIV Prevention Director for Alameda County Public Health Department. I use he, him pronouns. My first update is just kind of a check-in. We are still waiting to hear from the state about the impact recently about the decision to eliminate the HIV prevention branch at the CDC. All I know thus far really is that our project officer is still in place at the CDC. That he oversees the funding that comes from the CDC to the state that comes to us. Both of our HIV prevention contracts are federal contracts. We've not been notified of any shift in programs in priority populations or what have you. So we're still in the process of moving forward with the work that we are contracted to do and that we in turn subcontract with our agencies and are just waiting for kind of the impact of what this decision means. But right now it's business as much as possible as usual for us. So just to let you know that that's all I know. I don't think the state knows anything beyond that as well, and we'll update you as well. Those of you who do know Avery Ligo, she's our public health advisor with the CDC. She was not laid off this week. She was expecting to be laid off, but she was not laid off. So she's still with us, for now at least. Um, my biggest update right now is really in terms of the work that we're doing is many of you know that with Take Me Home, we can offer HIV testing, self-testing for HIV, gonorrhea, chlamydia, syphilis, and hepatitis C for any Alameda County resident 13 or older. We've recently been working with the staff at Building Healthy Online Communities, which manages Take Me Home. So we can now do appointments. People who are interested in getting on PrEP in Alameda County can log onto the website, create a porthole, order the tests, the HIV test kits, and then they have an option to create a calendared appointment with one of my staff. Right now, that's Avery, if they're English speaking, or Moises, if they're Spanish speaking, and they can talk about finding a local PrEP provider. Which is why it's a plug to make sure that your East Bay Getting to Zero directory, service directory is up to date, because we're referring people to providers in East Bay who we know that are able to offer PrEP, and trying to identify the client's best needs, whether that be linguistic or geographic, to make sure that we've got the best local provider for them. That's up and running since January. We've had, I think, 12 different appointments already scheduled, and I think 5 of them have been with monolingual Spanish-speaking individuals. We're about to do the same thing with DoxyPEP. Avery's been working with Curtis in the STD branch to make sure we have directory of DoxyPEP providers as well. And we're about to launch that as well. It's pending Curtis's final approval of that, and also making sure that Avery's going to be around for a length of time. But so we're going to be offering the DoxyPEP as well to help navigate people to DoxyPEP in the East Bay. And again, that's any Alameda County resident age 13 or older. That's it for me, Sammy.
Thanks so much, Steve. And do we have anyone from Office of Care here? I think I saw Stephanie.
Hi. Hey, everybody. I don't really have too many updates from the Office of HIV Care. Sorry, I wasn't prepared to necessarily give an update. We just had a town hall yesterday, kind of learning a little bit more about the needs of leakage and retention in our community. And we're working on, we were awarded, or we received a notice of award for ending the epidemic for kind of phase 2. So we're working on putting together an RFP that should be released later this year. And I think that is all I have to update off the top of my head.
Thank you, Stephanie. Didn't mean to put you on the spot.
No problem. Happy.
Um,
Hi.
and then anyone from Contra Costa that wants to give any updates from Contra Costa Health? I don't think I saw anyone, but please jump in if I missed you. Otherwise, we'll circle back to them and make sure that if they have any announcements for folks, we get them into our follow-up notes. All right. I'm gonna go back to sharing my screen and move forward with a few updates on the East Bay Getting to Zero side. So as folks might have heard, East Bay Getting to Zero is also in the process of sort of downsizing our operations, not surprising given the times. But we are able to continue some of our work. And so we wanted to let people know that we're still here, we're still functioning, but some of our work is going to be going at a different pace right now. But most excitingly, we just wanted to let people know that we were able to create a 5-year impact report, really summarizing all the work we've been able to do with all of you as partners through that first 5 years of the Ending the HIV Epidemic grant, where we were really rolling and getting a lot done. So thank you to all of you for participating. We wanted to share this out with you if you didn't already see it in our email blast a few weeks ago, but really just reflects a lot of the work that you all have put into our working groups, into designing materials with us, designing murals, designing campaigns to reach people in our communities, and coming together and sharing resources, best practices, all of that. So huge thank you to you for all of that, and we'll be continuing to do as much of the work as we possibly can going into the next 5 years. So with that, also just wanted to remind folks that this is kind of the current configuration of our working groups as they've evolved over time. So right now, I would say that our foundational groups are really our Care Continuum network, all comers, anybody touching HIV and syndemic services. We want us to all have places that we're getting together and connecting. We have our PrEP Navigators working group, which really focuses on frontline folks doing prevention work, and our Regional Case Managers working group, which really focuses more on the frontline folks doing HIV care and case management work. We still also have our Youth Sexual Health Services group. We're not having regular meetings right now, but still have folks on our email list and who we're sharing resources around that. So if you're interested, let us know and we can get you on that email list. And we still have our Grupo de Charla, so our Spanish-speaking working group, which isn't having regular meetings right now, but again, still has a really strong foundational core of folks who are sharing resources and that email list. And then we're still working on our AIDS Memorial Garden, so leave it surely in the background. So for folks who are still really inspired around working on that piece, that's going to be at the gardens at Lake Merritt in downtown Oakland. Of course, let us know, and we're happy to loop you into that work that we're doing too. So like I was saying, these are our current working groups, and also wanted to continue to give a shout out to the Gender Affirming Care Working Group that Han and Lexi from Asian Health Services have started. This is kind of an all volunteer effort at this point, but we're really trying to support them in getting this work going, because we know this is more important than ever to really have a strong network of people who are really affirming of and making sure people have strong access to gender affirming services. Lastly, as people know, that we've been working on the East Bay HIV strategic priorities over the past 5 years. And every year in the fall, we start gathering people's votes about what specific activities they really feel like we should be focused on in the East Bay. So I just wanted to share the results of what folks said was really inspiring them looking into 2025. So the top 3 areas that folks wanted work on, and there were pretty close ties in these areas, was coordinated street and mobile HIV services, substance use, harm reduction and recovery services, and care coordination services for people with HIV who are out of care. So a lot of interrelated work in there, and that's really where we're going to be focusing our efforts at East Beginning to Zero to try and make sure that we're at least shoring up people's abilities and capacity to do that work that people really lifted up as priorities. So that's where we'll be focusing our attention. And with that, we wanted to focus this Care Continuum meeting really around some substance use, harm reduction, and recovery services. There's been a lot of requests specifically focused on methamphetamine use, but I think really just the interplay of stimulant use, opioid use, including fentanyl, and kind of how all of that is coalescing and hitting our communities. So that's really where we're going to spend our attention today. So with that, I'm going to introduce our first speaker, who is Finn Black. They work for the SFDPH Center on Substance Use and Health. But we also know Finn, I think personally here in the East Bay from their work at the Berkeley Free Clinic for many years and leadership there. And we're so excited to have Finn give us this overview on care for people who use methamphetamine. That'll be followed by a presentation from the SFDPH Bliss Project, and then lastly followed by Caitlin from the East Bay Recovery Incentives Program. So with that, I'm going to hand it over to Finn.
All right, great. Thanks for having me. I'm just going to share my screen. Thanks for bearing with me for a second. Okay, someone let me know if this isn't working, but I think we should be good to go. All right, so thanks for the introduction, Sammy. My name is Finn, so I'm a registered nurse. I work as a research clinician at the Center on Substance Use and Health at SFDPH, primarily in drug user health research, especially around methamphetamine. And I also work as a resource clinician, educating providers about best practices in caring for people who use drugs. And outside of that, I've been involved in mutual aid and harm reduction work for about the past 15 years. No conflicts of interest to disclose, and any opinions presented here today are my own, not those of the San Francisco Department of Public Health. So today we're going to do a deep dive talk into the history, pharmacology of meth, what it does to the body in the short and the long term, how to provide good care to patients who use meth, regardless of whether or not they're interested in reducing or stopping their use. And, meth is one of the most stigmatized and misunderstood drugs out there. So one of my goals today is to correct some misinformation and misconceptions. And I know we don't have a lot of time, so I'm going to try to focus on content that's not easily accessible elsewhere. So for folks who want a more basic overview of things like harm reduction, stigma, working with folks who use drugs, I'm going to make a pitch for some resources at the end of this presentation and try to focus on stuff that you're not necessarily going to stumble across easily somewhere else. And I'm going to probably talk pretty fast through the first several slides because we're in a little bit of a time crunch and there is a lot of content to go through. So I just want to start by talking about what methamphetamine is in the first place. So chemically, meth is in a really big family of substances called phenethylamines, which includes several neurotransmitters our bodies make naturally, like epinephrine and dopamine, a whole lot of different recreational drugs like MDMA, MDA, mescaline, and amphetamines, and then a whole lot of pharmaceuticals like bupropion, seleginine that we use for treating Parkinson's, phenylephrine, the active ingredient in preparation H, and things like Sudafed. FYI for the molecules on that slide, that's methamphetamine on top, dopamine to the bottom left, and norepinephrine to the bottom right. So it has a really similar structure to some of the happy brain chemicals that our bodies naturally make. Pharmacologically, meth is what we call an indirect acting sympathomimetic and central nervous system stimulant. That first mouthful means that it activates our sympathetic nervous system, so our fight or flight part, without actually binding to any receptors. So meth isn't binding to your dopamine receptors or our norepi receptors, and we'll talk about what specifically it does in a second. The second part means it crosses the blood-brain barrier and it acts in our central nervous system to promote things like wakefulness and a sense of well-being. Like a lot of drugs out there, meth is chiral, so it comes in mirror image forms with different pharmacological properties. The old school term for this is having a left-handed form and a right-handed form. So dextromethamphetamine is the central nervous system stimulant. Levomethamphetamine is mostly a peripheral stimulant, so it has effects like increasing heart rate and vasoconstriction, but doesn't really cross the blood-brain barrier as much. And that's actually sold over the counter as a nasal decongestant, the Vicks Vapo inhalers that you can buy at like Safeway or CVS. We'll talk a little bit about more like why it matters to know that meth is chiral later on. In terms of mechanism of action, I know this diagram is really intimidating. Don't worry too much about taking it all in. So unlike opioids, which bind directly to our opioid receptors, meth doesn't bind to any receptors. That's why we call it an indirectly acting drug. Instead, it causes an increase in the availability of our own brain chemicals, mostly norepinephrine and dopamine, and to a lesser extent, serotonin. So we have this diagram here of a synapse. So that's a space where two different neurons are communicating with each other by releasing neurotransmitters. In the top neuron, meth is releasing stored dopamine from vesicles, which are these little storage chambers inside of the cell. So we have this sort of backup reserve of dopamine, and meth is making all of that go out there and be available. It's also blocking these little green guys labeled DAT that reabsorb excess dopamine. So those two things together kind of bathe that synaptic cleft, the space between the neurons, in just a total massive load of dopamine. You're getting all this extra release and you're preventing it from being reabsorbed. So it's acting for longer. It's not shown in this diagram, but meth also blocks the reabsorption of norepinephrine and serotonin, serotonin to kind of a lesser extent. So you have much more availability of these three different happy brain chemicals. That massive amount of dopamine is why meth feels so amazing. And the depletion of stored dopamine is why meth come downs can feel really rough because you don't have the sort of dopamine in reserve. So you can have several days after using meth where you feel pretty low. And it takes a few days for the brain to replenish that dopamine. And just FYI, this is the same mechanism of action as other amphetamines like MDMA and Adderall. What makes all of those amphetamines different is how much they act on each different neurotransmitter. So there's a different balance between like how much norepinephrine, how much dopamine, how much serotonin. And interestingly, methamphetamine and amphetamine are roughly equivalent to each other in terms of their action on each neurotransmitter. It's a myth that meth is like the most potent stimulant in existence. It's possible that the structure of meth makes it cross the blood-brain barrier a little bit more effectively than amphetamine, but we don't really have evidence that it's enough to be clinically significant. And we do have evidence that amphetamine might actually be slightly more potent in terms of its norepinephrine and dopamine release. And there have been clinical trials where people experienced in using meth were given either amphetamine or methamphetamine by the same dose and same route of administration and couldn't tell the difference. So the reason why we think of meth as a much stronger drug has to do with the dosages that people use and the route by which they use them. So in terms of drug effects, so we learned that meth results in this increase of norepinephrine and dopamine levels and a more modest increase in serotonin. So what does that actually do? So physiologically, you get all of the standard sympathomimetic effects: increased heart rate, increased blood pressure, increased body temperature, more muscle activity, greater respiratory drive and urine output, and appetite suppression. The central nervous system stimulant effects include things like feeling euphoric, feeling more confidence, talkativeness, desire to do things, relief of fatigue, wakefulness, and in some people, there's also an increase in sex drive. Then you also get a reduction in pain, especially neuropathic pain. And if that sounds weird, if you think about how we sometimes use SNRIs like Effexor, which increase your serotonin and norepinephrine to treat nerve pain, meth is also increasing your serotonin and norepinephrine, so that's not super surprising that it has pain-relieving qualities. And in terms of like what that does for people and why folks use it, there's a lot of different reasons why people use meth and other stimulants. That can include things like fun, pleasure, sexual enhancement, staying awake and functional, just being able to get things done that you need to do, self-treating conditions like pain or depression or ADHD, or just like feeling more confident and able to like socialize with other people. And we'll talk about this more later, but I really want you all to internalize that if you want to help somebody reduce their meth use, it's really, really important to understand what positive things they get out of it in the first place, because stimulants can be very useful and functional drugs. And if it's playing some kind of vital role in someone's life or helping them cope with certain things, we're going to have to find another solution to whatever problem someone is solving or whatever positive thing they're getting out of stimulants if it's going to be realistic and desirable for them to cut back. I'll also just say really quickly around chemsex. This isn't really a chemsex talk, but just because this is an HIV focused group, I want to say a few things. Meth is often associated with STI and HIV transmission. And in terms of like physiological effects, the big reasons for this has to do with the combination of having a lot of stamina for longer sex sessions, reduced pain, which we just talked about, pain relief, plus getting dehydrated. It's easier to have rough sex that results in tearing of mucous membranes with all of those different factors combined. And we'll touch on this again later, but also have it in your head that things like PrEP, doxyPEP, hydration, lube, all really great strategies for reducing HIV transmission in folks who use meth. Okay, so I am not able to easily monitor. Actually, there's the chat. Okay, I can see the chat now. So, quick pop quiz. Does anyone know, and you can just put in the chat, what year meth was invented, what plant-derived molecule meth was originally made from, or what that species of plant was, or what meth was originally used for when it was first invented? We have to go fast, so I'm just going to wait like maybe 10 or 15 seconds if people want to quickly type in the chat if they know the answers to any of those questions. I know it's a little bit nerdy and out there. Okay, we have a guess for 1950. Some people think it was wartime to keep soldiers up to fight. Japanese war pilots. We need to go further back in time. Really good guesses. All right, so let's get into the history of meth. 1890s, yes. Meth was invented in 1893 by a Japanese scientist who was studying the related molecule ephedrine, which you can still buy behind the counter as an asthma medication. It comes from the shrub shown here, ephedra. This picture is of one of the species that grows in California, which mostly contains pseudoephedrine, not ephedrine. So, quick refresher on the history of meth. So, invented in 1893. In terms of its original medicinal uses, in the 20s and 30s, it was available in some countries over the counter as a cold and asthma medication, similar to Benzedrine inhalers, which contained amphetamine. And the left-handed form of meth is still available over the counter as a decongestant. In World War II, amphetamine and methamphetamine were widely used by both Allied and Axis powers to help soldiers stay awake and alert in combat. A lot of people, like, there's this myth that meth was invented by the Nazis. That's not actually true. After World War II, meth was used as both a weight loss drug, an antidepressant, and as it was actually approved intravenously for a while for enhancing psychotherapy sessions, kind of similar to how MDMA is used for enhancing psychotherapy in some trials today. So kind of interesting because it could help people feel more comfortable connecting with a therapist and make them feel more interested in talking more. In terms of modern use, oral methamphetamine is still FDA approved as a second-line treatment for ADHD. It's approved for ages 6 and up, but it's pretty rare that it's prescribed because we have safer stimulants today. And it's sometimes used off-label for narcolepsy. So, brief history of street supply methamphetamine. So, historically, meth that was sold on the street was made through a reduction of pseudoephedrine or ephedrine, which made the more potent dextromethamphetamine. Regulations from the DEA led to it being a lot harder to access those over-the-counter medications, and so meth started being made by other precursor chemicals, especially phenylacetone, which produces a racemic mixture rather than just dextromethamphetamine. That racemic mixture, you might be able to guess from what we said earlier, is less potent and probably a little bit more skewed towards a lot of noradrenergic side effects. So if you've heard patients say that meth isn't what it used to be in the 90s, this is the main reason for that. And there's a lot of misinformation and sensationalized reporting about racemic meth that the new synthesis pathways have made something that's much more toxic or much more potent, but the reality is it's actually given us something that is less potent. There is some evidence that in recent years, some drug cartels have shifted to either purifying racemic meth, which depending on the technique gives a product with more or less of the dextromethamphetamine, or to actually synthesizing ephedrine and then making pure dextromethamphetamine from that. So the supply is always shifting in different ways, and it can be different in different geographic regions. It is really, really hard to tell the difference between the left and right-hand forms of a molecule. It requires much more expensive equipment than the kinds of equipment used by local drug testing programs. So this isn't something that we really have great data on. The DEA has a lot of drug testing data, but they don't make it publicly available. So it's hard to know exactly what is in the drug supply in different regions of the country, unfortunately. And, as more chemicals are banned, there's always going to be a move towards synthesizing precursors to precursors, which can change the types of impurities that appear in the drug supply. Meth that has been tested in the Bay Area by local drug checking programs is in fact just methamphetamine. So those drug checking machines can't detect impurities that are just present in trace amounts. So unreacted precursor chemicals aren't necessarily going to show up in those tests. But if you've heard people saying that there's fentanyl in the meth, that is, for the most part, a myth. Molecules don't really like to crystallize together. So if you have a substance that consists of crystals, it's probably just going to be one molecule, maybe with a little bit of trace contamination. It's pretty hard to cut something like crystal meth with other things and actually have it form large crystals. I'll also just mention as an aside that trace impurities in meth are sometimes removed by the end users using a process called acetone washing, where you put it in a coffee filter and you quickly pour anhydrous acetone over it. This is absolutely a thing that people frequently do, even folks who are unhoused and don't have a lot of resources. It's pretty easy to get acetone from a drugstore. Impurities tend to form on the outside of crystals, and meth isn't soluble in anhydrous acetone, so that is sort of one small harm reduction thing that folks out in the community will sometimes do if they think that the meth that they have might have like unreacted reagents or side products in it. Okay, so there's a whole rabbit hole we could go down with like the organic chemistry of drugs. I'm going to try to get through this quickly, so we're not going to go deeper into it, but just kind of wanted to get that out of the way. And another pop quiz. So I guess I already answered this question for you all, but it is not common in the Bay Area to find fentanyl and methamphetamine. I'll give a little bit more information about this. So in the Bay, the one situation where local drug checking programs are finding fentanyl and methamphetamine is if it's not in the form of crystals, but has been crushed up and is powdered. Fentanyl test strips will give a false positive, and yes, I see that question in the chat. Fentanyl can be mixed with powdered cocaine for sure. I don't have data on the top of my head over how often powdered cocaine is testing positive for fentanyl, however. Fentanyl test strips, especially the older ones, will give a false positive for meth if the sample isn't correctly diluted, which contributes to this widespread myth that meth is contaminated with fentanyl. So I've heard people in harm reduction programs when I've like been doing syringe exchange say like, oh, my meth tested negative for fentanyl, but then I put a bunch more meth in the sample and then I saw that there was fentanyl in it, so there must be fentanyl in the meth. What's actually happening is that there's cross reactivity with the test strips because the sample was too concentrated. Accidental fentanyl use among people who use stimulants more commonly happens because somebody picked up the wrong baggie of powder and they thought that it was a stimulant and it was actually fentanyl, or because people are sharing pipes and they accidentally picked up their friend's pipe that still had fentanyl in it. So other important strategies to have in your head are never using alone, using with folks who have naloxone. Something that some harm reduction programs will do is give out these little colored silicone bands or rubber bands so people can mark their pipes and not accidentally pick up their friend's pipe by mistake. Okay, in terms of like common dosages and routes of administration for meth use, I don't have a time to do a comprehensive overview of harm reduction strategies for different routes. So I want to make a plug for checking out nextdistro.org, and I'll put the link at the end of this presentation. They're a mail order syringe services program, but they also make really fantastic detailed materials on harm reduction strategies for every single route of drug administration that you could think of. So if you feel like you need a refresher on that, they're a fantastic resource. Most commonly, meth is smoked. Other routes of administration include injecting it, only IV. Meth is not a drug that you want to accidentally get into a muscle or subcutaneous tissue because it won't be absorbed. It'll be extremely painful and you're not going to feel it. It can also be rectally used. That's often called boofing or booty bumping. I will say that if you're looking for information on harm reduction strategy for using drugs rectally, get them from NextDistro. There are a lot of flyers out there from some harm reduction programs that give you incorrect information that increase the risk of rectal tearing and decrease the risk that you're going to have a good experience from the drug. Other routes include snorting, oral, hot railing. Dosages vary really, really widely. So therapeutic doses of meth are in the range from like generally 50 to 30 milligrams a day. The threshold for feeling an effect happens at around 5 milligrams, maybe even less, though there are plenty of folks who are using more than a gram a day. Usually something in the range of 50 to 150 milligrams is a common recreational dose, but there is really widely varying opinions and experiences from folks over what they think is a normal amount of meth to use. Okay, so pop quiz question number 3. Are methamphetamine overdoses common? Does anyone have any guesses? There's certainly been an increase in deaths that are attributed to methamphetamine, to acute methamphetamine toxicity. I see at least one no. Any other guesses? The no is correct. So it is common knowledge that it is incredibly difficult to overdose on amphetamines, at least to overdose accidentally. So meth has a really broad therapeutic index. The dosages that people are sometimes using can be 100 times higher than the dosages where you start to feel an effect from meth. We don't have an established LD50, so like a lethal dose for meth in humans. The LD50 in rats for meth would be the equivalent of a 150-pound human using about 12 grams all at once. Rats metabolize meth way faster than humans, so I'm not saying make extrapolations about this, but it is really unlikely that someone is going to have a event where they accidentally use more meth than they intended to and die from that. There's this term that's been thrown around. So overamp is not the equivalent to an overdose. So overamping refers to a subjective bad experience taking stimulants. It doesn't mean that you're having a life-threatening experience. It means that the place where your body was in that particular day, you're not feeling well. It's subjectively unpleasant. That might mean that you're feeling anxious and agitated, or that you're having heart palpitations, you're not having a good time. Doesn't necessarily mean that you're having a medical emergency. I do think that there's some harm reduction organizations, Dance Safe especially, that is sort of like put this thing out there that if you're overamping, it means you're like going to have a stroke or a heart attack and you need to call 911, and it maybe like spread some overly alarmist misinformation about it. But generally, when folks who use meth say that they're overamping, they mean that they're having a bad time, not that they are having a medical emergency. In terms of acute toxicity, so like in cases where someone did take too much of a stimulant and it is life-threatening, what that acute toxicity can look like can include things like cardiovascular events. So like their heartbeat has gotten so high that their heart isn't getting enough oxygen, or they're at risk of like a life-threatening arrhythmia. Cerebrovascular events from their blood pressure being too high. Things like rhabdomyolysis. So that happens from a combination of increased muscle activity, high body temperature, and dehydration. So maybe someone who is like on a run, at a rave, dancing for a really long time, getting overheated, and not drinking enough water. Those are what acute toxic events might look like. So if people aren't dying of methamphetamine overdoses, but there are a lot of deaths that are being attributed to methamphetamine, does anyone have any ideas about how meth might be contributing to mortality? And you can put it in the chat. So we have heart issues, congestive heart failure, I see. See, laced with fentanyl, but we already talked about how it's really unlikely that there's going to be fentanyl in meth. Health issues. So yeah, I think people are kind of getting there. It has to deal with chronic health complications from long-term regular use at high doses. So the mortality and morbidity related to meth primarily are related to chronic use. So when people are found dead in the community, they're often labeled as having died of an overdose if they have drugs in their system, regardless of what the actual mechanism of death is. There's a lot of limitations in how death determination happens. So chronic toxicity from meth use, we can roughly lump into two buckets: cardiovascular toxicity and neuropsychiatric toxicity. There's also some systemic stuff. So like a lot of us are kind of familiar with the idea how if your body is just amped up from chronic stress all the time, that can lead to chronic inflammation and be really bad for us and lead to a lot of comorbidities. So if you have a lot of adrenergic activation all the time, that can lead to oxidative stress and chronic inflammation and predispose you to other health problems. Just like if you have toxic stress from just like being a poor person living in the United States. Cardiovascular toxicities include things related to peripheral vasoconstriction. So meth tightens up your blood vessels and leads to increased vascular resistance and hypertension. We all know that hypertension is really bad for us. Hypertension plus systemic inflammation can lead to conditions like cardiomyopathy, and that can lead to congestive heart failure. Meth also prolongs your QT interval, which increases the risk of you having a fatal arrhythmia. Smoking meth is really irritating to the lungs and predisposes you to COPD, which can also lead to pulmonary arterial hypertension. Neurological toxicities are related to chronically elevated dopamine levels in the brain, so that eventually can promote psychosis. Do you think like many antipsychotic drugs are anti-dopaminergic for that same reason? Having chronically elevated dopamine in your brain also promotes neuroinflammation and can lead to things like early onset dementia. And over long term, having those chronically elevated dopamine levels can lead to damage in the dopamine signaling system. And then that can actually kind of give you the opposite spectrum of symptoms where you get like Parkinsonian-like syndrome. Everything on this diagram that is highlighted in purple isn't related to meth itself. It's related to things around social determinants and the way in which it's used. So COPD and lung disease has to do with smoking meth, STI and HIV transmission. Meth doesn't inherently cause that, but if someone is combining something that reduces pain, increases their stamina, and makes them dehydrated and combines that with sex, that makes it a lot easier for transmission to occur. If someone's injecting meth, especially if they don't have access to new supplies, that can predispose them to a variety of skin and soft tissue infections or HIV and hepatitis transmission. The poor dentition thing I want to say a few things about because there's a lot of stigmatizing information out there about what people call meth mouth. Meth doesn't inherently cause poor dentition. Like if you have ADHD and you're taking Adderall, your teeth aren't all going to rot and fall out. What's going on is a combination of people not having access to high quality dental care, possibly like coping with a dry mouth from meth by using a lot of sugar sweetened beverages or candy, not having a lot of saliva in their mouth, which protects us from teeth decay, and then just like access to oral hygiene. So if someone is using meth, but they're doing things like chewing sugarless gum and drinking water to keep their mouth moistened, and they're also like up on their dental care and are brushing their teeth every day, it's not going to cause all of their teeth to rot and fall out. Meth can also cause jaw clenching and more tooth grinding, which can also contribute to dental problems. So damage from the meth smoke. I have seen a couple of websites that haven't cited their sources that have said that if you smoke meth, it makes your enamel rot. I've only ever seen that on the Dance Safe website and on drug rehab websites. I've never seen anything that has like an academic or medical citation for it. So my guess is no. It's not impossible that that might be something that happens, but I've never seen anything that looks evidence-based saying that that happens. Okay, so pop quiz. Let's say that I want to quickly talk about pregnancy because the intersection of pregnancy and drugs really kind of amps up the stigma. Let's say that you're caring for a patient who just gave birth and they screen positive for meth. One, are you legally required to report that? And two, what fetal harms are known to be associated with using meth in pregnancy? And again, we're going to go really fast, but type it in the chat. See that one person says that yes, you're required to report that. Okay, looks like everyone is saying yes and that preterm and low birth weights. So this is a place where there is a lot of misinformation. So alcohol and tobacco have really well documented fetal harms. Both of those are legal. We actually don't have strong evidence that most illegal drugs cause fetal harm. There's a little bit of data linking stimulant use to intrauterine growth restriction and preterm labor, but those effects are massively diminished when you control for social determinants like housing status and income. Also important to know, methamphetamine is not known to be a teratogen. So we don't have great evidence for fetal harm related to meth use in pregnancy. Substance use in pregnancy is really, really stigmatized, and in a lot of parts of the United States, it is also criminalized. A lot of pregnant people who use drugs are reluctant to seek care because of concerns around criminalization and being reported to CPS. Really important to be aware of that. Also really important to be aware of what the law actually requires. So most of the time when police and CPS are notified on a pregnant and birthing person in California, there wasn't actually a legal requirement to do so, and it was sort of over compliance for fear of getting in trouble for not reporting. There have been a couple of cases in California where providers or nurses called the police or CPS because a patient had a miscarriage and tested positive for meth, and the patient was then jailed. But that notification isn't actually required by California law, though it will likely still result in the patient being arrested and jailed, or in a case where someone's given birth and they test positive and they're reported, in the kid being taken away. It's really important to remember that pregnancy loss is common. It can happen to anyone. It should never be blamed on the patient. There is no requirement to report a miscarriage to the police or CPS in California. The Academy of Perinatal Harm Reduction produces really good toolkits that go into more detail about specific substances and fetal harms, even like things around breastfeeding. And there is a really lovely map on the ProPublica website that breaks down what the law is state by state. So There's a lot of myths and misconceptions around healthcare workers around what is legally required when they learn a pregnant or birthing person uses drugs, and fears of liability tend to lead to a lot of over-reporting. So although using drugs during pregnancy isn't illegal and is not considered child abuse in California, those results can still result in jail time or family separation. So laws vary widely state by state. I'm going to give you a summary of what the law is in California. Screening or testing a pregnant person for drugs cannot be done without that patient's informed consent, and patients can decline those tests. There's no laws mandating that they get tested. If someone has a positive test during pregnancy, that is not considered child abuse in California, though it is in a lot of states, especially in the South. Pregnancy loss is not a crime in California. There are states where engaging in behaviors that lead to pregnancy loss is illegal. That is not true here. A positive urine drug screen in a pregnant person does not require CPS notification. The Child Abuse Prevention and Treatment Act is a federal law that required states to have policies on reporting infants that were exposed to drugs during pregnancy to CPS, but California never adopted that law and never implemented it. We never adopted that policy. So infants exposed to drugs do not have to be reported to CPS. So for example, if an infant is born with neonatal abstinence syndrome and the birthing parent tests positive for opioids, that's actually not something that you're legally mandated to report, but a lot of hospitals will over-report anyway. So there might be a hospital-based policy for reporting. It's not actually legally mandated. Most reporting happens either because of clinic or hospital policy or because providers are worried about liability and they are over-complying. So again, not because it's actually mandated. So change really happens at the levels of nurses and providers and hospitals and social workers. And there are states that legally mandate substance use treatment in pregnancy. California isn't one of those. So just want to kind of get that out of the way because I feel like it's increasingly important in the current political climate. All right, so let's get into the nitty-gritty of caring for patients who use meth. So we advocate for something called the 4-tier approach to patients who use meth. In brief, this consists of 1, understanding the relationship to meth, so what positive things they get out of it, anything they perceive as negative or that they want to change, how they feel about change. 2, providing all of the basic preventive services, so vaccines, STI and HIV prevention, harm reduction supplies, etc. 3, offering use reductions resources if someone wants to change their relationship to meth. So that can include things like contingency management or certain medications. And 4, interventions to help prevent some of the chronic toxicities if use is occurring on a regular basis. So assessment, general principles about being non-judgmental and non-stigmatizing apply. Patients might not share your goals or views around their drug use, so it helps to not be attached to a specific outcome. So don't expect that everyone is going to stop using drugs. People take stimulants because they're pleasurable and useful. So if someone is interested in cutting back, we really want to understand what role that drug is playing in their life. So there's some example questions on this slide that you might use when talking to a patient about stimulant use, and you're going to have access to these slides. So I'm not going to sit here and read them because we got to move kind of fast. Just remember that if we don't give that person a different tool to use, cutting back on stimulants may not be realistic for them. In terms of how methamphetamine use disorder is diagnosed, drug use becomes a use disorder when it's no longer under someone's control and is causing harm. So in short, substance use disorder is continued use despite negative consequences or wanting to stop and cut back, but not being able to. Clinical criteria for use disorders are found in the DSM-5. There's a summary of them here. And the criteria are the same regardless of the substance use. So you diagnose methamphetamine use disorder the same way that you would diagnose opioid use disorder. So routine prevention, this tier includes things related to generally keeping someone healthy, like routine vaccines. Some interventions that are really relevant to stimulant use include preventing unintentional fentanyl use. So if you're going to give out test strips, make sure people understand the importance of diluting things correctly. Marking pipes with rubber bands. If you're using with other people who also use opioids, making sure that you're not accidentally using your friend's pipe or your friend's drugs. Marking your baggie with a Sharpie so you don't get mixed up with someone else. Everyone who uses drugs or is around folks who do should have access to naloxone, even if they don't intentionally use opioids themselves, because even if they might not need it, they might be around somebody who needs it. Injection alternatives to reduce the risk of infection transmission, so things like safer smoking supplies and booty bumping supplies are really, really important. It's really fantastic that there's been such a big transition from people injecting drugs to smoking drugs in the Bay Area. It's really helped to reduce infection problems. And then especially if someone is into chemsex, making sure that we're offering them PrEP or long-acting injectable ART, doxy-PEP, post-exposure prophylaxis, HIV, hepatitis and STI testing, things that all of y'all are probably very familiar with already. Okay, so let's talk a little bit about use reduction. We now have several effective tools for helping people reduce their stimulant use. Contingency management, which I think y'all are going to learn more about today, which I'm really excited about, is the behavioral intervention that basically gamifies reducing stimulant use. So you win cash or prizes for cutting down. That usually means giving a negative urine test. This is currently the most effective intervention that we have. Around 1 in 4 people will become abstinent from stimulants while engaged in a contingency management program. So that's a number needed to treat of 4. There's not a lot of things in medicine where we have a number needed to treat as low as 4. And even if someone doesn't become abstinent, most people are able to cut down. Medi-Cal now reimburses for contingency management, and there was a preliminary analysis of pilot programs in California that found that around 95% of submitted urine samples were negative for stimulants. And even if you counted all the missed visits as times that somebody would have been using, the figure was still 70%, which is absolutely phenomenal if you're familiar with like outcomes from other use reduction programs. Currently, contingency management programs are limited. I'm based at SFDPH, so I'm going to let the other speaker go into what the East Bay's landscape looks like. And regardless of whether someone is able to do contingency management or if they are and they want to get some additional support, there's several evidence-based medications that we have. They're all off-label. There's nothing yet that's FDA approved. The recommendation is to start with either bupropion or mirtazapine. They're both meds used for treating depression. Bupropion has the added benefit of being stimulating because it's an amphetamine itself and helping with smoking cessation, which a lot of folks who use meth also smoke tobacco. Mirtazapine promotes sleep and increases appetite, which can be really helpful for someone who's underweight and has disordered sleep from their meth use. Either of those meds can be used in combination with naltrexone as long as that patient isn't also using opioids. Naltrexone tends to have better adherence when given IM, but really for best efficacy, it has to be dosed every 3 weeks, which insurance won't always cover because it was approved for being dosed every 4 weeks. Oral naltrexone is a fine alternative. Naltrexone's nice because it also helps reduce alcohol cravings, and if someone's trigger for stimulant use is they go out drinking and then they want to stay out late and then they use stimulants, naltrexone can kind of help interrupt that cycle. For patients for whom all of that's not adequate, that's a really good time to refer them to see an addiction medicine specialist. There are cases where using amphetamine-type stimulants like dextroamphetamine can help reduce someone's meth use. There is a solid evidence base for this, but in the state of California, it's likely illegal to use them for that purpose. So you can't prescribe amphetamines to treat a stimulant use disorder. It is, however, legal to prescribe amphetamines to someone who uses street supply if you're trying to treat that person's ADHD. And if someone's reason for using stimulants is that they have untreated ADHD, that could actually help reduce the use of street supply. There's a little bit of an evidence basis for topiramate, but it works best in conjunction with amphetamines. It has a lot of side effects. It has to be titrated really carefully. It's not something that I would recommend that primary care providers need to worry about. Okay, finally, I want to talk about toxicity prevention. So anyone who uses stimulants on a regular basis, regardless of whether they have a use disorder, regardless of whether they want to stop or reduce their use, should get information about chronic complications of long-term stimulant use and ways to reduce it. The health impacts of long-term stimulant use, I'm not saying that they're totally avoidable, but they're probably not totally inevitable, and there's likely things that we can do to reduce them. When I say regular long-term stimulant use, we mean high-dose daily use for years. So like the example we often throw out is using a gram of meth a day for 10 years. We don't have a cutoff for what constitutes toxic use, but in general, if someone's just taking like 100 milligrams or so once a month on a weekend to have fun, we're not really considering that long-term toxic use that we're worried about. But if someone is using meth every single day and they're doing that for years, we're more concerned about chronic toxicity. I want to talk first about the heart and then about the brain. So one of the biggest things that we can do to protect someone's heart is the same as for any other patient. So like smoking cessation, access to healthy food, management of cardiac conditions like hypertension and tachycardia. There's really this problem with undertreating high blood pressure in folks who use stimulants on the assumption that you're not going to get blood pressure under control until they stop using stimulants. You don't have to get someone to stop using meth for them to get their hypertension treated. Ditto for heart failure. You can treat both of those things in the setting of ongoing stimulant use. Those patients should get access to the standard of care. I'll also say it's safe to give beta blockers to people who use stimulants. There's this really long-term myth of this thing called unopposed alpha stimulation. That myth has been thoroughly debunked, and if we have time for questions, you can ask me more about it. That's kind of a rabbit hole that we could go down. I'll just say that the myth of unopposed alpha stimulation was based on a study in the 1980s with an N of 12, where the results were never reproduced, and the study itself was like kind of wacky. Having a really low threshold for offering a beta blocker, also really reasonable in folks who use stimulants. So like in someone who's like often a little tachycardic, like their heart rate tends to be in like the low 100s, might make sense to offer that person a beta blocker. Statins are an interesting intervention that we're starting to recommend for folks who use meth regularly. Statins can reduce the risk of cardiovascular disease in people who lack traditional risk factors. So some of y'all might heard of the Reprieve trial that found a benefit in people living with HIV who otherwise wouldn't have been recommended for statins, but because of the chronic low-grade inflammation from HIV infection, they were at increased risk of cardiovascular disease, and statins reduce that risk. Stimulant use isn't included in cardiovascular disease risk calculators, even though it really should be. So this isn't yet an evidence-based recommendation. We don't have any robust studies backing this up, but some providers in San Francisco are starting to offer statins for the theoretical benefit of reducing cardiovascular risk. We don't know if the type of chronic inflammation seen in long-term meth use is going to be the type of chronic inflammation that is going to be amenable to treatment with a statin, but it might be something that you want to consider. And again, like happy to talk more about that in the questions. In terms of the brain, the big things are sleep promotion and helping someone minimize going on multi-day runs. Being up for multiple days is really bad for your brain, also really bad for your heart. Mirtazapine is a really nice drug for sleep promotion. If you're going to give someone a statin anyway, it's reasonable to choose one that crosses the blood-brain barrier, like a torvastatin, because those have a theoretical neuroprotective benefit. Okay, so that's toxicity prevention. That's all the content that I had to present. I know we're kind of almost cut for time, but if anybody has questions, I'm happy to chat for the next 5 minutes before we move to the next person. And thank you for everyone who's been answering each other's questions in the chat, because it was hard for me to talk and monitor the chat at the same time. There's a really great question here about safer pharmacological alternatives for those who have been using meth. So because of the law in the United States, this isn't something that is done, but in Canada, they do have safe supply for people who use stimulants where you can get a prescription for dextroamphetamine to help you reduce your use of street methamphetamine. And thanks, everyone.
Thank you so much, Finn. So much love in the chat and appreciation for that incredible presentation. Just going to give anyone one last chance for questions. I think a lot of them were getting discussed in the chat, but if there's anything else that people want to throw out to Finn, feel free.
And I'll just put my email address in here. And you're all going to get access to the slides, right?
Yes.
At the end, there are several links to like further resources for people who do want more background on just like harm reduction information. And my email address is just my name at sfdph.org, so it should be pretty easy to remember.
I have a question.
Can I go or?
So
Yeah, go for it.
It's having an overdose with crystal meth. How should we treat her? How should one react?
So, like I said, actual overdoses with meth are really uncommon and they're treated with supportive care. So if someone has taken too much meth and they have, say, a fatal ventricular arrhythmia, that's going to be treated with advanced cardiac life support by the paramedics, and then they're going to be transported to the emergency department and it will be managed there. Whatever it is that they're dealing with. So if they have rhabdomyolysis, they're going to be in the ER, they're going to be getting IV fluids and interventions to help bring down their body temperature. If their heart rate is too fast, they're going to be getting beta blockers. Meth it's not like an opioid where it's binding directly to a receptor, and if someone takes too much, you give them a drug that blocks that receptor. There's not like a naloxone for meth.
Yeah, thank you.
Yeah, of course.
And I guess a related question, and then I know Maurice wanted to jump in, is what about people who are overamping? So if they come to you and they are kind of like acutely trying to figure out how to get.
Totally. It's a really great question. So what you want to do is figure out, is this person having a medical emergency or not? So ideally, you get a clinician involved. If someone is having symptoms of a cardiac emergency or a stroke, you would want to call 911 and get that person to the emergency department. If they're just feeling anxious, depending on how agitated they are, you might consider whether or not it makes sense to get psychiatric emergency services involved. If they're going to need, for example, like prescription sedatives to help them calm down. Otherwise, getting them into a safe, supportive environment that's quiet, low stimulation, and helping that person calm themselves down, making sure that they have plenty of water to drink is a reasonable response. And there's actually a few clinics in San Francisco that are starting to give out something called a chill pack, which is a little packet of self-administered low-dose olanzapine, so that if you've taken more meth than you meant to and you're feeling agitated, you can actually self-dose yourself with low doses of an antipsychotic to help yourself calm down. And there have been some preliminary data showing that it helps to reduce psychiatric emergency services utilization.
Maybe. Maurice, I think you have one.
Yeah, no, I just wanted to say, first of all, amazing presentation. Thank you so much for the info. Can you all hear me, by the way?
Yeah, we can hear you.
Thank you for the information. I'm really like I'm so let me go back. So I am this is something that I've been struggling with for the last 5 years. I have 5 friends that have 4 of them who are no longer here. You know, they were folks living with HIV who died, you know, from complications of HIV. Of course, they were all using meth. And I've been struggling because I've been trying to advocate for them for years about ways that I could help and support them. And it was like very limited resources. I currently have a friend right now who's on dialysis. He's only 37 years old due to his meth use. And so it's been a struggle to really find good research. So this has been great. I would love to get more information and maybe possibly even have like a side conversation, just so I can kind of pick your brain, because this is something that I've been struggling with, just to like, how do I support folks?
Totally.
And yeah.
Yeah. Thank you for sharing that. I have to jump onto another call, but did you get my email address in the chat?
I did not, but I will look in there and get it.
Yeah, it's just fin.black@sfdph.org. Feel free to reach out to me and I'm happy to chat.
Sure. Thank you so much.
All right. Thanks so much, everyone.
Appreciate it.
How much
Take care.
fun.
All right. Bye.
All right. And we're just going to jump into our next presentation. We're going to have folks from the Bliss Project presenting. So I'm going to invite Raul Ruiz to go ahead and jump on, share your screen. We also have Aaron Wilson and Willie McFarland from the team here with us. And forgive me if I'm leaving out anybody else on the team, but they're going to give us some updates on the study that they've been doing both here in San Francisco and in the East Bay, so we can hear a little bit more from some of our substance using communities in the East Bay about their experiences with substance use and HIV services. Feel free to jump in whenever you're ready, Raul.
Sorry, having a little trouble with my camera. One sec. Hi, everybody. Hi. Sorry, this thing just toppled as I was about to speak. Hi. Hey, my name's Raul. I'm a field coordinator for the Bliss study here at the Center for Public Health Research. This program's led by my PIs, Willie McFarland and Aaron Wilson. And we just wanted to share some of the information and data that we've gathered over the last year, now that recruitment is done for this study. Hopefully, I'm sure that some of this information and data will inform some of the work that you are up to. And again, thank you for making time to have us speak and talk to you all. I'll just jump right into it. The Bliss study, it stands for the Brief Longitudinal Incidence Sentinel Surveillance Study, and it's basically a cohort of 600 folks, 300 in San Francisco, 300 in Oakland. It's in Alameda County, but basically most of them came from Oakland. And it is a 2-year, once people are enrolled, it is a 2-year study that tracks the health behaviors of folks. I'll just sort of get into it and share a little bit about what that looks like and what enrollment was like, and then some of the data that we've gathered. And I need to share. Here we go. Can you all see that?
Yes.
All right, great. So there's Bliss, and here we go. Okay, so cool. So just the makeup of our participants. To participate, folks needed to be 18 years of age or older, a resident of Alameda or San Francisco counties, and they had to have injected drugs in the last 3 months upon making contact with us. So again, like I said, it was open to Alameda, so any region or city within that county, but a giant bulk of the participants ended up being from Oakland. And basically what happened is we went out and we did some outreach among places where we knew that people, or we assumed that people were gathering who were drug injectors. So our first participant ended up coming from HEPAC, who has been a valuable partner over at their mobile site in San Pablo. So basically, upon making contact with an eligible participant, they would carry out a baseline survey and a rapid HIV test on site. So they would get their results, within 5 minutes of getting their finger stick. And then we would gather information, contact info, email, phone numbers, any other parties that we might be able to reach out to if we lost contact with the person. And then at that point, these individuals would get sent a quarterly follow-up, right? So to both their email and phone numbers. I'll talk a little bit about the difficulties that have come up from that. But anyway, from these quarterly follow-ups, the study hoped to then identify HIV cases as time went on, and then to get a sense of that sort of changes in drug use, or to capture any kind of like emerging or re-emerging substances out in the communities. So let's see. And then basically the study made use of people's social networks, aka starfish sampling. And we did this in 2 ways. So one is by doing RDS work, which meant like upon enrolling in our study, people would get 5 coupons to hand out to people in their communities, people in their networks, and then they would get financially incentivized for doing that. So whenever someone brought a coupon back, the person who referred them would get $10 for this. I should also say that enrolling in the study was the whole study was financially incentivized. So it was $50 for someone enrolling, and then $10 for these coupons. At the same time, we were then doing time location sampling, again, partnering up with areas, organizations where we knew that people from this community would frequent. So that way we'd be able to kind of capture folks who maybe were not being captured by the social networks of the coupons that we were handing out. See? And then here's just kind of like a breakdown, a little glance at what the study progress looked like. We started in April, a year ago. So back when the world was so much more innocent. Anyway, so we started it here, and then it went on, and as you can see, Oakland started first, and it took a while for the study to kind of gather its legs. I think it took a month before we made contact with one individual who then started recruiting people. So there's that. And then as you can see, these plateaus here in Alameda County have occurred. And I think that really speaks to the sort of like disparate nature of a lot of the communities out in Alameda County and Oakland. So in San Francisco, a lot of the people are sort of just physically located in one region here in Alameda County. And so we could easily find people who wanted to enroll. In Alameda County, we would sort of exhaust these networks and then have to start again in other places doing outreach. So I think these plateaus really speak to the sort of like spread out nature of the communities out there. Right. And then here's some of the characteristics, the demographic characteristics of the participants. So for the most part, and I'll focus just given the nature of this group on the Oakland group. So 63.4% of the participants were men. And then for the most part, folks were the majority of folks here in Oakland were 40 to 49 years of age, followed by 50 to 59. So San Francisco skewed a little younger by 10 years. 34.8 was the sort of like the bulk of them, and then 32.4 from 30 to 39 ages. So, and then ongoing, here's some of the demographics. So the 59.5% of the folks were Black or African American in Oakland, whereas in San Francisco, 51% of them were, which I think speaks to the sort of like the racial makeup of the two cities. 56.4 and 59.5% of our folks were unemployed. And then very importantly, 64.8 and 66.9 of our participants were homeless or had reported being houseless in the past 3 months, which I think obviously has an impact on, as I'll talk a little bit more down the line, has an impact on people's stability and then our ability to kind of capture them as time goes on. But yeah, so there's that. So I'll move on here. This I think is really interesting. And it's wild, right? Because the two cities are really, they're separated by nothing but a bridge. I mean, they're so close to each other, and yet, like, once we gather data, they're very distinct substance cultures that exist within these two spaces. So in Oakland, the drug of choice that was captured was, for the most part, heroin. Speaking of injection use, so there's 46.8% of our participants were injecting heroin. Whereas in San Francisco, that number, the 45.6% of the folks were injecting meth. So, and potentially has something to do with like the age group. I think that older folks were marking heroin use, especially in Oakland, as opposed to the sort of like slightly younger crew in San Francisco that was injecting meth. And then here, so let me show you a visual representation of this. So in Oakland, we have heroin, 47% of folks were doing that, followed by meth. Whereas in San Francisco, we have the majority of folks were doing meth, followed by fentanyl. Here's some information on the prevalence that we were capturing, HIV prevalence. Interestingly, we captured 0 new infections in Oakland, 0 new HIV infections. And I am talking about the sort of HIV test that happens at baseline. 0 people tested positive, and we are done with recruitment at this point. So we're done. So we captured 0, whereas in San Francisco, we captured 6 new cases. And as you can see from self-reported cases, immediately as San Francisco started, the prevalence, we started capturing people who were self-reported positive. And so moving here, this is what these numbers look like. So overall, the HIV prevalence in Oakland at this point is 5%, just from our cohort of 300 people, whereas in San Francisco, we're at 6.8. And then, so yeah, these are self-reported. And again, the number of cases just upon initial impact, initial contact, we were 0 in Oakland and 6 in San Francisco. Here's some healthcare utilization some data that we gathered. So interestingly, a great majority of the folks are being covered by health insurance. 88.6 in Oakland reported having a form of health insurance, with the majority of them being covered by Medicaid or Medi-Cal here. However, 57, just slightly over half of folks reported receiving medical care in the past 3 months. And super interestingly, when probed, people mentioned, like here in this instance, 34.8% of folks delayed or avoided seeing a doctor or receiving other medical services due to fear of discrimination or stigma from healthcare providers. Yeah, and then 22.7% of folks felt discriminated against when actually seeking healthcare. And this is from a variety of sources, right? So it could be like emergency rooms, it could be through a primary care provider, it could be through a mobile clinic, that kind of thing. Move on here. Here's some PEP and PrEP use data. So I feel like this is where sort of a lot of the efforts potentially are lagging behind. I think it's in Oakland, 27.8% of our participants reported just basic awareness of PEP, with only 1 person in the cohort having used it in the last 3 months. PrEP is a little higher. 135 folks reported awareness of PrEP, but again, only 1 person reported PrEP use within the last 3 months. And then there's the following slide actually, there it is, yeah. And then moving here, and this is occurring, so this PrEP and PEP, like low usage, is happening while high-risk behaviors are still occurring. So in Oakland, for instance, 19 folks both used a needle after someone else injected with it, or gave their used needle to someone else to use after having used it. However, 98.3% of participants received harm reduction supplies. And there is interest for a safe consumption site in both spaces, pretty overwhelmingly. So these risk behaviors here are broken down between HIV negative and HIV positive cases, right? So skews toward the negative case, toward people who are negative. Nevertheless, people who are HIV positive are still reporting sharing of needles here in Oakland. It was 0 in San Francisco, interestingly enough. But yeah, there's that. I will continue. And then in terms of sexual behaviors, 69 in Oakland, 69.6% of folks reported having had sex in the last 3 months, with 39.4% of folks reporting more than one partner. And then 11.5% of folks in Oakland reported having sex with people that they actively injected with. Again, the breakdown between HIV positive and negative folks in the cohort is here. So again, it skews a little bit more toward these folks who are HIV negative are engaging in these behaviors more. But this is still happening. 3 folks reported having sex with people they injected with. 5 folks reported having more than one partner. And then there's people doing carrying out sex work. So it's 2 and 19. So here's a little bit of the so these numbers here are so the numbers are a little higher now, especially at the 3-month follow-up. So these are quarterly numbers, right? So it's every 3 months people get these surveys that they're supposed to fill out. They can also contact us and we can do it for them. There's at this point 28% of folks had completed at least one of the follow-up surveys, but then the number kind of starts dropping, right? So the second one is people who had completed all 2 follow-ups, and then people who had completed all 3 follow-ups. At this point, we're just about to get into the 12-month follow-up. So everybody is the most that kind of like the highest peak as people are getting into that 9-month follow-up period, which is here. So this really speaks to the difficulties in finding a lot of folks within this community. I think that obviously there's sweeps that are happening, and with such high numbers of our participants reporting houselessness or housing instability, it makes it so that even when people report or let us know that they usually hang out in a place, or that their campsite is at a particular location, when we then try to go out there and find them, these places are no longer there, or we're just finding a lot of movement that we're frankly struggling to catch up with. Just it seems to change really on like a week-to-week basis, this sort of like stability. I know that the camp around HEPAC, where they park over at San Pablo, there was a camp there that had been stable for quite some time. But then there was a sweep that happened like 2 months ago or something like that. And so a lot of those people are now lost to follow-up, and we have not been able to track them. Again, folks are always welcome to call us and get a hold of us that way. But as we all know, there's so much that the lives that people are leading are so, full with just busy with just like the element of survival, that I think keeping in touch with us every 3 months is like one of the last things that they're thinking about. So completely open to hearing some suggestions, or if any of you has done work that kind of mirrors or mimics outreach in this way, we would really love to hear some of the strategies that you all used. But yeah, that's it. That's all we have for you all. Thank you all so much for making space and time. Really appreciate it. If you all have any questions, the PIs are here. We'd be happy to answer some of your questions.
Thanks so much, Raul. If folks have questions, I think for the sake of time, please feel free to throw any questions you have in the chat and we can make sure that they get back to the team. And any suggestions or information you have about encampments and folks and how they might be moving around that you think would be helpful, let them know. Because as we can see, we get really useful information about how well we're reaching folks with things like PEP and PrEP services, how connected people are feeling to care, what some of the barriers are for folks coming back to care, right? And really thinking about some of what Finn was just teaching us about how we can be more harm reduction focused when people do finally come to seek services with us. So I think there's a lot of overlap with all the work that we're doing to really understand some of our substance using communities better. And we really appreciate you sharing that data with us. And lastly, to shift gears a little bit back into treatment and recovery services that are available, we invited Caitlin Wallace to present to us about the recovery incentives program that's happening here in Oakland. So if we remember, Finn was telling us about how one of the most evidence-based recovery programs we can use is something called contingency management. It's just starting to be piloted in California, and we're fortunate enough to have a site here. So I'm going to pass it over to Caitlin to share a little bit about our local site that's offering the services for people using stimulants.
Awesome, thank you. Let me get my screen. All right. So I'm Caitlin Wallace. I am the program supervisor / counselor at the adult outpatient substance use counseling in Oakland. So our address here, we are on Fruitvale. We do outpatient harm reduction counseling, groups, individual counseling, and some case management in Alameda County. We are also incredibly lucky to have been the pilot program for Alameda County's recovery incentives. So that contingency management recovery incentives are kind of used interchangeably. So the name of our program is recovery incentives. All right, I'm just going to dive right into it. So RI, recovery incentives, it's, as Finn mentioned, one of the most powerful ways to help people stop using stimulant use. It's a program that UCLA launched, I want to say maybe a year ago. And it's been associated with increased abstinence for up to a year after treatment. So it's a behavioral intervention for SUD, substance use disorder, when using tangible reinforcers, so gift cards, in our case, are provided when an individual meets a goal for reduction or abstinence of one of their target substances. So recovery incentives has been applied to other treatment-related behaviors, such as attendance. Ours is linked to stimulant negative test results, and only stimulant negative. I do really want to make that an emphasis. The tests that we use will test for a myriad of different substances. It does not matter if the participant tests positive for marijuana, alcohol, opiates. The incentive is only really looking to decrease stimulant use. It is harm reduction based. Our program in general is harm reduction, so we don't want to stigmatize use. I think Finn said it really beautifully that people are in different places with their recovery. Some do want to completely stop. Some just want to limit or use in a healthier, safer way. And our program in general across the board really just tries to reiterate, follow that person where they're at and what their goals in recovery are. So it is a behavioral therapy. It's based on operant conditioning. So we're trying to increase a behavior, right? So that being in decreased stimulant use. Sorry, the language is a little confusing sometimes. So there's 3 methods of changing behavior in operant conditioning. You can either use positive reinforcement, negative reinforcement, or punishment. So recovery incentives utilizes positive reinforcement. And then this is my opinion, I don't think punishment works very well for substance use disorders. If it did, the drug war would have been over a very long time ago. And I think what's so beautiful about this program is that it's just trying to meet people where they're at and reinforce the behaviors that we want to see. Not using substances, making appointments on time, coming into sessions and checking in with their counselors, right? And so that's the desired result that we want. So what we are going to do is reinforce that behavior by giving gift card incentives. So you can kind of see the breakdown. It's a little jargony. So the desired behavior, which is the stimulant negative UDT. So the drug test desirable result is the gift card incentive for increased stimulant abstinence. A brief overview of who's eligible for our program in Alameda County. So you must be 18 years or older, Alameda County resident with active Medi-Cal. So Medi-Cal does reimburse through the incentive. So they have to be on Medi-Cal. I will say our program is able to enroll clients and help them get onto emergency Medi-Cal if they don't already have it. Our program specifically does also take health pack or other low income. This program specifically requires Medi-Cal. And then you must have a moderate or severe stimulant use disorder. So that's what Finn was talking about from the DSM, which basically means that you check off, I want to say 5 to 6 is the minimum of those diagnostic criteria, which would be unable to stop using, craving to use, and, you know, severe, not severe, but consequences because of your use. You cannot be enrolled in a residential treatment program while in the recovery incentives program. You can be in a, SLE, a sober living environment. You just can't be in a residential. So it is a standalone program, which means that participants are able to come in and only test. The testing sessions are about 15 minutes, just the time to collect the sample, wait for the results. It's a rapid UA, so it's pretty quick. And then inputting the results into the platform, dispensing the incentive. So all of that takes about 15 minutes. However, we do really encourage participants to attend group, increase additional services, but they are able to just come in. So it's kind of a low barrier for clients or for participants to just get them in as much as possible, as quickly as possible. So the program itself is a 24-week program. It is an in-office visit, 2 times a week for 12 weeks, and then 1 time a week for the following 12 weeks. So the Recovery Incentives Program incentivizes up to $599 for not using stimulants. So it's measured by, as I already said, negative drug tests. So I'm going to pause there and just say that the sessions themselves are very short. The incentives increase each week to kind of get into the nitty-gritty of it. It's actually really fascinating. I'm going to nerd out for just a second. They found the way to kind of, it starts at the $10 and then it slowly increases by $1.50 every time, because they find that if it's just the standard 10 every single time, people kind of lose interest in it. So they've really been able to design the program in a way that keeps them engaged, that keeps participants engaged and earning up to that $599. Let's see. So some of the kind of common questions that we get. Well, I think there was a lot of stigma in the beginning when the program was launched about paying people to stop using drugs. I will just say from my own experience, I have not had to field that question, which is amazing, because I do think that it's so helpful to recognize that the way that stimulants interact in our brain, they hijack that reward pathway. It's very, very, very hard to stop using when you have that level of dopamine that you're used to getting from a stimulant. It's very hard to find anything else that's kind of that same tangible, that benefit. So this is really kind of that way to start getting that, kind of taking your brain back a little bit. So the small incentives are kind of help to encourage clients to, or participants to choose abstinence over the continued substance use. So as far as slips, lapses, or drug or ongoing drug use, relapse is a part of recovery. And I think that anyone that has had any time with people that use substances genuinely understands that. And so this program really doesn't look to stigmatize or punish, but it does emphasize accountability. So if a client or a participant comes in, or if they miss a session, they are paused. Their earning is paused for that visit. The very next one, it'll reset for that $10, and then it'll immediately increase. So they don't lose any of the time and the earnings that they've had, because you really want to keep people engaged and not feel punitive when they're coming into sessions. So I already kind of said it is a standalone treatment. However, what we really do is try to encourage clients or participants to come to group sessions. we have a really amazing staff that will notice if people decrease their stimulant use, but all of a sudden maybe increase their opiate use or something else, because to Finn's point, we're usually using because we're getting something out of it. So it's a great opportunity to try and address some of those issues in those individual sessions and say, hey, maybe you want to come to a group session. Maybe we want to check out some of these other things that might help with your recovery. So I just want to be mindful of the time. So this is our location. Let me check the chat just to see if there's any specific questions. Please feel free to email me or call. We do accept direct referrals. You can call that 300 number. That's our front desk. You can call me. Sometimes it's a little harder for me to get if I'm doing a meeting or something like this, and email me with any questions. And with that, I will pause. Does anyone have any specific questions?
Caitlin, is there a time limit on when this program is going to be ending, or a maximum number of people you're going to be enrolling, or it'll be?
That's a great question. We do not have, we don't have a cap on how many participants we can have. So we are a little bit of a smaller staff. We've got 4 counselors right now. The program itself, though, we can take, there's no limit, I guess is all I need to say. So we are accepting new referrals. We usually get them in pretty quickly within about a week from the first point of contact. The program specifically is funded from UCLA and Medi-Cal, and it's going until December of 2026.
Okay, great. And do you offer any transportation assistance for folks?
We do offer bus passes to and from treatment. We're working on getting Clipper cards.
Any other questions from folks? I know we're hitting just 11:30 right now, but if there's any last questions, feel free to throw them in the chat. I think Maurice might be asking for your email or the email program. Thanks everybody who's here. So just wanted to close out the meeting really quickly. I see one question that just slipped in. How can we direct patients to this or similar programs?
So right now, direct referrals, let me put I accidentally did it to the wrong one, my phone number and email in the chat. I believe I don't believe, we are currently the only one in Alameda County right now offering contingency management. I do know there are some other programs that are looking to get up and running, hopefully the start of the next fiscal year. But yeah, right now, direct referrals to the following number.
All right, and then I was just gonna close things out really quickly. There is an evaluation for today's program in the chat. If folks can just open that up and fill it out, really helps us know what to keep doing, what to do next, helps us stay funded to keep these meetings going. We'll also send out a link to the evaluation in our follow-up where we'll be sharing slides from today as well. Just wanted to alert people to something that I think just came through a lot of inboxes this morning, and we'll share it out again. But this is something happening today at 1 p.m. our time, a webinar on how to advocate for HIV and housing programs and the protection of them. More important than ever right now. And it's going to be part of a week of action next week. So if people want to join that, we'll send out the information so people can jump on that really soon. Local upcoming meetings and events. We have the regional case managers meeting, which Alameda County Public Health Department is going to host this next one coming up. Oh, sorry, that should be in 2 Thursdays on April 17th. So contact Georgia for this one rather than East Bay getting to 0 if you haven't received an invite. The PrEP Navigator meeting will be happening with Jane. Our Pause Plus committee, again, if people living with HIV are interested in joining that, we're still having monthly meetings. Please reach out to Jane if you're interested in joining, and we'll connect you to the next steps on that. The Gender Affirming Care Working Group, that's happening on a volunteer basis is going to next meet on Friday, May 9th, and you're going to contact Han at Asian Health for information about that. And then the HIV Clinical Care Conference, mostly focused on our clinical teams and providers, is going to be on Tuesday, May 13th, and you can contact me if you want more information about that. That's all I got. Thank you everyone so much for being here today.